Now let's go on to our last topic for the day, which is pattern strabismus. And I hope you all have enjoyed this until now and you all are following it through. So wake up. Let's start with pattern strabismus. It's going to be a quick, short topic with one question that we're going to take from our question series. Okay. So how do we define a pattern strabismus? So we call it a pattern strabismus when there's horizontal strabismus deviation between an up case and a down case. There is a difference in the magnitude of the deviation. Now, an A pattern deviation is when you have a difference of more than 10 prism diopters. That means it is more divergent in the down case than in the up case, or it is less convergent in the down case than it is in the up case. This is typically seen at about 25 degrees in the up and the down case. Now, V pattern strabismus is a difference of 15 prism diopters or more. Now, this is diverging more in the up case. So, pattern strabismus is defined by the way it looks. So, this is the A pattern and this is the V pattern. So, with V pattern, we are seeing that there is more exotropia on the top or less esotropia on the top. And in A pattern, we are seeing that there is more esotropia on the top or less exotropia on the top. Correct? This is the primary understanding. Why is V pattern given 15 prism diopters in the definition? Because there is a normal convergence which is more inner, which is what we're accounting. Right? Now, these are two pictures where we are looking that the squint is more. This is a patient of exotropia. The squint is more at up case and less in the down case. And this is a V pattern. And here we look at this exotropic patient wherein it is more in the down case than in the up case, and which is a case of A pattern. We also see that when the patient is AB ducting, the left eye is over elevating in adduction. Here, the right eye is again over elevating in adduction. And over here we see that the left eye is over depressing in adduction. And again, the right eye is over depressing in adduction. So etiopathogenesis of this is based on multiple factors. The first being oblique muscle dysfunction. So it was earlier known that inferior oblique overactions are more associated with V pattern and superior oblique overactions are associated with A pattern. But we're going to call it, instead of inferior oblique overaction, we will call it over elevation in A deduction and over depression in A deduction for superior oblique overaction. Now, orbital pulleys can be displaced. That means if our horizontal muscle pulleys are displaced vertically or the vertical muscle pulleys are displaced horizontally, they cause a dysfunction in the way they act. The vectors of the muscle forces change, which is what results in this pattern strabismus. So craniofacial anomalies and slanted palpebral fissures have these displaced muscle pulleys which cause pattern strabismus. Ocular torsion, that means if the eye intorts, it causes more of an A pattern strabismus, and if the eye starts extorting, they will start developing a V pattern strabismus. Also, when you have a tight horizontal rectus because of some restrictive element like a tight lateral rectus, you will develop a pattern like an X pattern strabismus. So let's look at the types. V pattern strabismus is the most common strabismus and it's often associated in cases with infantile esotropias, also with bilateral esopalsies. So superior oblique palsies will cause inferior oblique overaction or over elevation in A deduction, and also craniofacial anomalies which cause the pulleys to be altered. A modification or a type of the V pattern is again Y pattern. So when we talk of V pattern, we say that up case, primary and down case, there is progressive increasing in divergence superiorly or reduction in convergence superiorly. Now, when we talk of Y pattern, we are talking about the fact that there is not too much of a difference in the down gaze in the primary position. However, in up gaze, there is more divergence. This happens in associations of pseudo inferior oblique overaction, which is more innervational. And typically they are negative for tilts. That means if you do the head tilt and you check for the vertical strabismus, you won't see that, or there won't even be any torsion. So these patients have a pseudo inferior oblique overaction. So we must not work on the inferior obliques to correct this pattern, but it will be better corrected by using the horizontal muscles only. Now we come to A pattern, which is the second most common type of pattern deviation, and it's often associated with exotropia and spina bifida. Lambda pattern is again a type of A pattern. So the way we said V pattern and Y pattern are subtypes, A pattern and lambda pattern are subtypes. In lambda pattern, in up gaze and primary position, there's not much of a difference, but in down gaze, we see more exodeviation or less esodeviation. An X pattern, as we discussed earlier, is often associated with large angle exotropias with tight lateral recti. So that means there is more exodeviation in up gaze as well as down gaze because the globe slips under the restricted leash effect of the tight lateral rectus. Now, this is a picture of a child where we see there is some craniofacial anomaly. We see that the globes are proptosed looking because of the shallow orbits. There is a slight slanting palpebral fissure, and when the child looks up, it is a case of a right exotropia, but when the child is looking in up gaze, we see that the exotropia is far larger. So we come to our question, what is the most type of strabismus which is associated with craniosynostosis? We've shown you a patient of that, and the answer may be easier now because it is a V pattern exotropia, which happens because of multiple causes: the excyclorotation of the orbit, the pulley system, and the muscle pathways alter because of the orbital anatomy and result in this V pattern exotropia. I'm going to show you this video of this child who was brought to our clinic with parents complaining that the child would constantly use a chin up position at most points in time. So if you see this child, when the child is looking straight, there is an esotropia in the right gaze. When the child looks down, the eyes look almost perfectly aligned, but when the child looks up, there is an obvious right esotropia. I'm going to show it again. There is an esotropia in primary position, which is almost aligned in the chin down, chin up position, but worsens when the child looks up. Also look at the Bruckner's reflex over here. We see that when the child looks up, down gaze is where he prefers keeping the chin up so that his fusion potential is more. Now you see this color over here in the reflex, which is the Bruckner's reflex to pick up strabismus in a squinting eye in young kids. So abnormal head positions are also a clinical feature or manifestation of the strabismus, where patients will adopt a head posture where the fusion is the best or the strabismus is the least. How do we manage these cases? This is an excellent diagram or table which is adopted from AAO series again, which you all have with yourselves. And what I want you all to see is if we have a V pattern strabismus with over elevation in A deduction, if you have the over elevation in A deduction, you have to weaken the inferior oblique muscle. But if you do not have an over elevation in adduction, then you would prefer to transpose the horizontal recti muscles so that you correct the pattern. We will come to how we transpose these horizontal recti to correct the pattern shortly. Similarly, if you have an A pattern, if there is associated over depression in adduction, then you will weaken the superior oblique muscles. But if there is no over depression in A deduction, then you will only decide to transpose the horizontal recti vertically. Okay. Now, when you decide on transposing these horizontal recti vertically, we are actually trying to alter the vector forces and the path of the muscle where the action is happening so that we reduce the pattern strabismus. So this is an easy way, and the mnemonic to remember this is MALE. That means the medial recti are shifted towards the apex, medial, A towards apex, and the lateral rectus towards the empty space. E is the empty space. So medial towards the apex, MA, lateral towards the empty, LE, empty space. So in an A pattern strabismus, put the medial recti up, lateral recti down, and in a V pattern strabismus, medial rectus towards the apex, downwards, and the lateral rectus towards the empty space, that means upwards. So easy way to treat these patients. The important clinical pearls includes, first, identify if there is any over elevation or over depression in A reduction. If you do get it, then you have to work on weakening the obliques. So if it is a V pattern, you will weaken the inferior oblique, and in an A pattern, you're going to weaken the superior oblique. Look for torsion. If you have this oblique overaction, you are going to have torsion. So with superior oblique overaction, you will have an intorsion, and an inferior oblique overaction, you have extorsion on the fundus. We have gone through the mnemonic MALE, which is going to help you remember where you're going to transpose the horizontal recti so that you're going to get a correction of the pattern. Now, what we must also remember is when you want to offset this, you want to offset it bilaterally, because if you're going to offset it vertically, you may induce some torsion. And that may be okay only if you have an amblyopic eye, which will not have torsional diplopia postoperatively. Now we have a muscle width. How much of the muscle width should we transpose vertically up or down horizontal of the horizontal muscle? So it's defined that you normally get about 15 prism diopters by shifting a half tendon width. That means about 5 millimeters from the center. If you go up or down, you're going to correct about 15 prism diopters of pattern strabismus. We reserve a full tendon transposition of the muscles only when you have a very large pattern, because when you have a very large pattern and you alter the path by a complete tendon shifting vertically, the effect on the horizontal strabismus correction is not very predictable. So it is reserved for very, very large patterns. We prefer to do only a half tendon shifts otherwise. Now, if you have a superior oblique overaction, what you can do is the posterior tenotomy of the superior oblique. Only 7/8 of the muscle is tenotomized so that you get a 20 prism diopter correction almost in the pattern without correcting the torsion, right? So you're going to not affect the torsion but affect the pattern. And if you have a larger pattern, you may decide to lengthen the superior oblique tendon to weaken it, and this can be done by using a suture, or we use a chicken suture or a spacer in the middle so that we elongate the superior oblique tendon to weaken the superior oblique muscle and get better pattern correction. Now, if you have a very large pattern like 40 to 50 prism diopters, only in these cases you may consider using a complete superior oblique tenotomy of bilateral tendons. You have to be very careful in these patients to not induce torsion. Whenever you're doing these muscle weakening positions, you must remember to do it equally on both sides so you do not cause differential torsional diplopia postoperatively. This ends our talk for today. Now I would like to thank Dr. Ashiana Narayani for having me over and addressing you all. I hope you all have enjoyed the talk and learned something at the end of the day. Most of the images and flowcharts are from the AO series, which you all can go back to and refer to, also from Kenneth Wright's handbook, and of course our patient clinic, which I'm grateful to. Thank you all for patient listening. Have a lovely day learning. And if you all have any queries, feel free to reach out to me on my email address. That's pooja.r.gogri@gmail.com. Thank you so much, everyone. Bye.